Arterial blood gases. So respiratory acidosis, we're going to have hypoventilation, which means that we're retaining too much CO2. And then in respiratory alkalosis, the hyperventilation means you're blowing off too much CO2, just like, I don't even know if I kept that video or not. So our treatment is going to decrease the ventilatory rates if they have too much O2 or too little CO2. Respiratory acidosis treatment, we're going to increase the ventilatory rates. Metabolic acidosis, so there's a buildup of lactic acid, lactic acidosis, in which case they could be in diabetic ketoacidosis or renal failure, sepsis, and toxic ingestion of some sort. Controlling the respiratory rate is going to matter. IV fluids and sodium bicarb is going to be important because bicarb is the opposite of acidic. Metabolic acidosis, their sodium bicarb is lower. Treatment, increased sodium bicarb. Metabolic alkalosis, a rare loss of hydrogen ions, vomiting, or gastric suction. Consumption of a large amount of baking soda or antacids. To treat, we're going to correct the underlying condition, so pump the stomach. Yeah, we don't want to we don't want to pour acid in their stomach to counteract that. It'd be a terrible idea. So examples would be pH of 7.2, 8, and CO2 54, sodium bicarb 24. So what's the pH doing? Well, pH is low, so they are acidic. If it's below 7.34, yep, 7.35, it's acidic. Now, which of the other values are also acidic? This is right where it should be because it's not 22 and it's not 26, so it's sitting in the middle. However, CO2 means that that is definitely acidic. So if sodium bicarb is not acidic and it's normal, we're not in metabolic acidosis, we are in respiratory acidosis because it's normal respiratory acidosis. CO2, yeah, everything I just said. So CO2 is normally 35 to 45, as we can see that it's heightened, which means it is normal and acidic. So HCO3, cool, respiratory acidosis. I'm smart. Believe it or not, as a paramedic, students, we cover ABGs on surface level. Oh well. Let's see what we got. Here we go, capnography. This is interesting. All right, so whenever we're looking at the capno, we typically, like we just said, 35 to 45 is within normal limits. Yeah, capnography is gold standard in endotracheal intubation and confirmation, also with heart attacks as well, or infarction. So in AHA, class 1, it's recommended for cardiac arrest, meaning that there's no patient risk and all benefits in the case of this, because it is class 1. So we discussed values of CO2. Let's look at the capnogram and capnography waveform. So we're looking at this graph, right? X-axis is always time. Y-axis is expired CO2 in this case. So breathed out carbon dioxide. This is our period of inhalation, that amount of time, and then our period of exhalation. So as you inhale, suddenly you detect CO2, it gets up here. Well, you stop breathing out, which is why the CO2 line is up to here, but also your body is still going through the period of internal and external respiration, right? Like there's still cells dividing and functions happening, which is why this line goes up slightly. There's still a slight increase in CO2 even after you have inhaled. And then we exhale, we breathe all that CO2 out, flat line. This line up here is what it's measuring whenever you're looking at your capnography. It's measuring your ET CO2. Expired CO2, alveolar plateau. I'm trying to figure out what the T stands for. Phase 1, respiratory baseline, flat with no CO2 is present, corresponds to the late phase. This is everything I just said. Yeah. So what normal capnography means or looks like. We have a normal square square box waveform, so EtCO2, 35 to 45 millimeters Hg in this case. And then we have a dislodged endotracheal tube right here because we have our boxes. Suddenly they disappear because we're not getting any readings since we're no longer in the esophagus or in the trachea as we should be, epiglottis. The esophageal intubation or apnea, absence of waveform, absence of EtCO2 reading, management, we need to ventilate or intubate because nothing is happening. Capnography waveforms, so we have different looking ones. This is important, I didn't know this. CPR, so we have the same square box waveform, however, it is all the way under 20 to the point where it's at 15 almost. During CPR, now if EtCO2 falls below 10 millimeters Hg, then we need to change out our rescuers for the rolls. Obviously, we are not perfusing enough and we are not doing accurate compressions. Shark fin, I believe it's asthma. Yep, asthma. So shark fin waveform with or without prolonged expiratory phase. So they're breathing and they're still breathing, right? Like there's not a sharp stop. It's a very long form and then it stops and then it goes down. So because it's prolonged expiratory, that means that they're not getting enough air. It means a lot of things, but they have asthma, could have COPD, anaphylaxis, or foreign body airway obstruction in their throat, FBAO. Can be seen before an actual attack or exacerbation, so it might not necessarily be happening yet. Management, bronchodilators, and treat the underlying cause. So our bronchodilators we have are epinephrine, whether it be injected or if it is through nebulized epinephrine. We also have Atrovent, I think Atrovent is one. What's the other one? Hypotropium, albuterol. Atrovent and albuterol, racemic, epinephrine, and then epinephrine itself. ROSC, return of spontaneous circulation. So that's what this looks like. It starts out smaller, and now we're getting back to within normal range. We want to make sure we check the femoral and carotid pulse whenever we're managing this. So this will happen during CPR and a sudden increase in our EtCO2. Looking at a rising baseline, so patient is rebreathing CO2. It's not exiting the system. Management, we want to check equipment for adequate oxygen flow. If we have a bag valve mask or something else, allow enough time for exhalation. We want to ensure that the cuff itself has a good seal. Hypoventilation. So if there's a prolonged waveform, EtCO2 of greater than 45 millimeters Hg, management is to assist in ventilations and increase respiratory and ventilatory rates. If we have hyperventilation, shortened waveform, EtCO2 is less than 35, our management is to slow respirations, ventilatory rate, and we want to consider other causes of diabetic ketoacidosis as well as sepsis. TCA, I forgot what that is. The cranial aneurysm, transishmic attack. Tension pneumo. I don't know. I can't remember what TCA is. Overdose, methanol ingestion. Yeah, all these can happen. This is interesting. Breathing around the endotracheal tube. So you have like a weird angled, almost like I want to say arrowhead. I don't know. It looks like a pile driver drill bit. So a sloping downstroke on waveform, we have a ruptured cuff or ET tube is too small. So our management is to check cuff and tube size and possibly re-intubate if necessary. If you have a curare cleft, that means that the neuromuscular blockade is wearing off, right? Our RSI drugs that we gave them, whether it be, which one's the neuromuscular? I want to say etomidate. Etomidate paralyzes. Succinylcholine is a hypnotic. Yeah, I'm going to re-go through those slides. Patient takes a small breath that causes the cleft. So normally they're not supposed to breathe on their own, but because it's wearing off, the body's natural tendency to breathe just kicked in, and you have a little notch there. Consider re-administration of neuromuscular blockade medication. So respiratory emergencies we have include COPD, chronic obstructive pulmonary disease, asthma, pneumonia, acute respiratory distress syndrome, pulmonary embolism, hypoventilation syndrome, pneumothorax, acute mountain sickness, and high altitude pulmonary edema. COPD, we have chronic obstructive pulmonary disease. It is an umbrella term that covers both chronic bronchitis, emphysema. You may have found that the asthma is at times classified under the COPD umbrella, but many argue that because it is fully reversible, it is not considered COPD. For us, we're just going to leave it at chronic bronchitis and emphysema. So you have two different types of this. You have chronic bronchitis and you have emphysema. Chronic bronchitis, also known as the blue bloater, typically this person is overweight. Productive cough with sputum. The difference between emphysema and that, so they'll have phlegm, they'll have mucus in their cough. Coarse bronchi, because it's thicker mucus, right? You're going to have bronchi instead of crackles. Chronic cyanosis, they'll be gray or blue. They're not going to be bright red. Blue bloater. Mild chronic dyspnea, so their breathing is all over the place and mild and constant. Resistance of inspiration and expiration, so you're going to get a little bit of resistance there. Then we have the pink puffer, so thin, barrel-chested appearance, emphysema, non-productive cough. There's not going to be sputum. There's not going to be phlegm. Pink complexion, so they're not cyanotic, and they have extreme dyspnea on exertion, so all over the place breathing, prolonged inspiration, pursed lip breathing, clubbing of the fingers due to edema. We have oxygen and bronchodilators, Dilneb albuterol 2.5 and 3 millimeters, and ipratropium 0.5 milligrams. Consider steroids for inflammation. We're going to consider CPAP. That way we can force air into their alveoli. With asthma, we want to do bronchoconstriction, inflammation, dyspnea, intercostal retractions. So like your intercostal muscles that you can feel in between your rib cage. So it's going to go in. They're going to retract. Inability to speak in complete sentences. They might have like a staccato type of speaking. EtCO2 is going to be over 45 millimeters Hg because it is not efficient breathing and there's going to be more carbon dioxide in their system. Tachypnea, fast breathing, tachycardia, fast heart rate to compensate. And then status asthmaticus means they've been having an asthma attack more than 5 minutes, and Atrovent and other bronchodilators are not working. Just like status epilepticus is having a seizure longer than 5 minutes. Management, we have oxygen and bronchodilators, Duoneb, albuterol 2.5 and 3 milliliters, and ipratropium 0.5 milligrams. Typically, we're going to give 2 of these, so we're going to load up 5 milligrams, at least with, I believe, Hillsborough's protocols is the case. So you load that in the nebulizer, snap it in place, give them a mask with O2. Consider steroids for inflammation, and IV fluids, epinephrine IM. This is Solumedrol 125. Yep, that's typically what we give. Consider CPAP as well because they're struggling to breathe, so it's going to help breathe for them. Pneumonia and ARDS, acute respiratory distress. I should just stay on this side. Infection that causes an acute inflammatory response. You have bacterial, viral, fungal. Could be all different types of pneumonia. It's interesting. I didn't know there was fungal pneumonia. Productive cough. You're going to have pleuritic chest pain. So yeah, there's going to be sputum, nasty crap in the cough. You're going to have a fever. You're going to have fatigue, wheezing, crackles, or bronchi. You could have any of those. So just like we talked about before, if it's crackles, it's fine. It's all the way out in the bronchioles, basically, of your lungs. It's not all the way in the thick part like the bronchi sound that you'll hear. And yeah. Acute respiratory distress syndrome. So it's a form of hypoxemic respiratory failure, result in non-cardiogenic pulmonary edema. It doesn't have to do with the heart. significant pulmonary edema leads to severe hypoxemia or intrapulmonary shunting. So it's going to redirect a route that it normally would not go, reducing the lung compliance and irreversible lung damage. You're going to get some trauma with this. And 65% mortality rate is not good odds. Rapid onset of difficulty breathing with pulmonary embolism, so it's just going to happen out of nowhere, especially high suspicion in patient without a significant cardiac or respiratory history, right? If you someone with a history of asthma, we're going to suspect asthma, but if they don't have anything and they're struggling, then oh no, pulmonary embolism. They're not able to do this. So common patients, they're bedridden chronically or after surgery, right? They're not moving around. What does that mean? That blood, sticky platelets aggregate and got caught in their pulmonary vein or artery. If they're on a long flight, right, stationary, see a common theme here, history of deep vein thrombosis, DVT, so it can become dislodged. Like, I think this is the thing with truckers actually, because they're sitting in their chair for so long, their seat, that whenever they stand up, suddenly like a thrombus breaks off and travels all the way into the lung pulmonary vein. Female patient, teens to 40s, on birth control. Interesting. Birth control increases levels of estrogen, progesterone, which have been proven to increase blood clots. History of smoking, that's just bad all around. So signs and symptoms: coughing, pain, anxiety, hypertension, high blood pressure. Rapid onset dyspnea, just out of nowhere, tachypnea, tachycardia, crackles, wheezes, and rhonchi. So treatment, we want rapid transport, get them out of there, get them to the hospital, diesel and steel. Additional EKG findings, higher level, not necessarily at entry level. Okay, so this is important. Our right axis deviation, right? We talked about that. So if our axis deviates, the electricity is supposed to go this way, and suddenly we're going this way, we're going straight down or somewhere in between 4 o'clock and 6 o'clock, then that's a sign. And then also we have S1, Q3, T3. So this is interpreting our 12 lead in our T wave. It is going to be T1, so in lead 1, our T wave is going to have an issue. In our lead 3, we're going to be looking at our Q wave, and we're also going to be looking at our S wave. I got that wrong. T3, Q3. So Q3, T3 in lead 3 is going to be issues with the T wave and Q wave. And then our S wave is going to have problems in lead 1. So S wave in lead 1, Q wave in lead 3, T wave in lead 3. So T wave is going to be inverted. At the end of the QRS, the big thing that we always look at after that, instead of the T wave repolarizing the way it should, it's going to repolarize upside down. And we'll have an S wave in lead 1, so that slight curve that comes up. Once the patient's entered a shock state, we want to administer 20 milliliters per kilogram fluid bolus, repeating as needed to support blood pressure if they have obstructive shock. And I think that's probably a good stopping position for now.